Good day, everyone. I'm Pooja Joshi, your host for today's episode. In this session, we focus on a condition that is common yet often misunderstood: irritable bowel syndrome, or IBS. To help us navigate this important topic, we are joined by Dr. Reyaz Ahmed, gastroenterologist at Noora Hospital, Srinagar, a respected expert in functional gastrointestinal disorders. Today, Doctor will walk us through early symptom recognition, simplified diagnostic approaches, and effective, evidence-based management strategies for IBS in routine clinical practice. Doctor, thank you for being with us. Let's begin our discussions.
Hi, I am Dr. Reyaz Ahmed, consultant gastroenterology and hepatology, working in Srinagar Noora Hospital.
So, doctor, question for you is, what exactly is IBS and how would you describe it in simple terms to a non-specialist?
IBS is irritable bowel syndrome. It's basically a functional gastrointestinal disorder. After thorough investigation of symptoms, when we are not getting any definite organic diagnosis of a disease, then we label such patients as having irritable bowel syndrome. That's IBS.
In your experience, how does a typical IBS patient present in an OPD?
IBS patients present with varied symptoms. They may present with pain abdomen. They present in change in the frequency of stools, change in the form of stools. They present with bloating. They present with abdominal distension. Sometimes they present with loss of appetite. They may have varied symptoms they present with. And there is always an association with pain abdomen. It has been seen. This pain is almost maximum time which is there.
What are the top 3 red flags that make you suspect IBS in a patient?
Top 3 red flags that I will tell: 1, there is pain abdomen, abdominal discomfort and pain. 2nd, there is change in the frequency of stools. And 3rd, there is change in the form of stools. And there is improvement of symptoms with defecation.
What simple screening questions can a consulting physician ask to suspect IBS?
For IBS, there is a definite Rome 4 criteria that we follow in our OPDs, that we ask every patient regarding pain abdomen and its duration. If the duration of symptoms is there for at least once in a week for last 3 months and symptom onset 6 months back, there is association of this pain with change in the form of stools, change in the frequency of stools, and improvement of the symptoms with defecation without any red flag signs, without any red flags. Red flags, what I mean by red flag is there's no blood in stools, there's no weight loss, there is no any other organic disease.
How important is the patient's history compared to investigations in IBS diagnosis?
In IBS, history is cornerstone for diagnosis. You have to take a detailed history, especially history of the onset of symptoms, history regarding red flags, which should not be there, which I already discussed. It should be particularly regarding any stress, any other contributory factor that may worsen the symptoms of IBS.
What are some common mistakes in diagnosing IBS at the primary care level?
See, what happens at the primary care level, that physicians should focus more on history taking and picking up the right points. A mistake is in over-investigating such patients, getting through them through a lot of investigations and who are with a lot of tests like CTs, colonoscopy, endoscopy and all. If we focus on history, if we focus on simple investigations, definitely we may get into diagnosis of IBS, and we don't need to do such expensive tests in all the patients.
Once IBS is diagnosed, what is your first-line approach to management?
Once we get a diagnosis of IBS, first thing should be to reassure the patient. Reassurance is very important. Reassurance regarding there is no organic cause. We don't need to worry about the disease because it's not there is nothing wrong with your internal organs actually. So we need to counsel the patients that how does this IBS happen, how does this occur, and we should focus on any other contributory factors like stress. We should focus on managing the dysbiosis, that is change in the bacteria in our gut. So focus on simple things might help in initial management. Definitely, we need to go ahead with pharmacotherapies also, giving medications for such patients, but that should be always to the point.
What's your opinion on the role of rifaximin in IBSD? Where does it fit best?
Rifaximin has been shown it works well in IBS-D patients, especially those patients who have bloating, who have diarrhea, and who have associated dysbiosis. Dysbiosis is there is altered ratio of our bacteria, so that's good bacteria and bad bacteria which are there in our gut. So it does help in such patients, and it fits best in those patients who have these IBSD and who have the history that they have improved with rifaximin, and where we suspect there is dysbiosis. For example, where there are comorbidities like diabetes, or where there are history of prior intake of antibiotics and all. So we can help them with this rifaximin.
How do you decide when to repeat a course of rifaximin or switch to another therapy?
We can repeat in some subset of patients where we have already known that such patients, any patient have improved with rifaximin, we can repeat in those patients. If there is no improvement, then we can switch over to another therapy.
What's the role of diet? Do you recommend low FODMAP, fiber modification, or any particular dietary pattern?
Diet has got a role in IBS patients, especially we recommend low FODMAP diet. Low FODMAP means fermentable oligosaccharide, disaccharide, monosaccharide, and polyols. Those diets are low in these are known as low FODMAP diets. It has been shown that low FODMAP diet help in symptom improvement. And second thing, which is very important, is fiber modification, giving soluble fibers more than insoluble fibers. And a third thing is avoiding certain triggers like lactose, or the patient's already known to allergies for some food, we can avoid that.
One myth you'd like to bust about IBS.
One myth that I would bust regarding IBS is that IBS is definitely a disorder with a known brain-gut axis pathogenesis. It has a pathology, but there is no organic, there is nothing wrong with intestines, there is nothing wrong with, in terms of organic disease, means there is no ulcer, there are no malignancy, there is no serious condition with the gut. But what is there is some alteration in gut-brain axis, and this pathogenesis is there. It's not an imaginary disorder. So we need to tackle it at all the levels, from brain to gut, so get with the treatment.
Thank you, Doctor, for sharing such valuable insights on IBS. Your clarity and practical guidance will certainly help both physicians and patients approach this condition with more confidence. To our listeners, thank you for joining us. Stay tuned for more expert-led conversations. Until then, take care and prioritize your gut health.